What are the signs and symptoms of neutropenic sepsis, and what immediate actions would you take if a patient presented with them?
Neutropenic sepsis is a medical emergency that can occur in patients with a low neutrophil count, especially those receiving chemotherapy or other treatments that suppress the immune system. The signs and symptoms may include a fever of 38 degrees Celsius or higher, chills, sweating, increased heart rate, low blood pressure, rapid breathing, confusion, extreme weakness, and feeling generally unwell. Sometimes patients may not show obvious signs of infection because their immune response is reduced. In a previous role, I cared for a patient who had recently received chemotherapy and suddenly developed a high temperature and chills during my shift. I immediately recognized that these could be signs of neutropenic sepsis. My priority was to act quickly because delays in treatment can significantly increase the risk of complications. I performed a rapid assessment using the ABCD approach, checked the patient's vital signs, and escalated the situation to the medical team without delay. I followed the local neutropenic sepsis pathway, ensured blood cultures and other required investigations were obtained as prescribed, and prepared the patient for urgent intravenous antibiotics. I also administered oxygen as required, maintained close monitoring, and documented all findings and actions accurately. Throughout the process, I reassured the patient and explained what was happening. As a result, treatment was started promptly, the patient's condition stabilized, and they recovered without developing severe complications. This experience reinforced the importance of early recognition, rapid escalation, and timely intervention when caring for patients at risk of neutropenic sepsis.
Can you explain the procedure for safely administering an intravenous chemotherapy infusion, including the checks required beforehand?
The safe administration of intravenous chemotherapy requires strict adherence to policies, protocols, and safety checks because these medications can cause serious harm if errors occur. Before administering chemotherapy, I would first ensure that I am appropriately trained, competent, and authorized to administer the specific treatment. I would verify the patient's identity using at least 2 identifiers and confirm informed consent has been obtained. I would carefully check the chemotherapy prescription against the treatment protocol, ensuring the correct patient, drug, dose, route, frequency, and timing. I would review recent blood results, including full blood count, renal function, and liver function, to confirm that treatment criteria have been met. I would also assess the patient's current condition, allergies, vital signs, and any side effects from previous cycles. In a previous oncology placement, I assisted with the administration of intravenous chemotherapy for several patients each day. A key challenge was ensuring accuracy while working in a busy environment. To maintain safety, all chemotherapy medications were independently double-checked with another qualified nurse according to local policy. I also inspected the intravenous access device to ensure it was functioning correctly and monitored for signs of infection or extravasation. During the infusion, I closely monitored the patient for adverse reactions and regularly assessed vital signs. I provided education about possible side effects and encouraged the patient to report any discomfort immediately. By following these safety measures and maintaining vigilant monitoring, chemotherapy was administered safely and effectively, helping to reduce the risk of complications and ensuring high-quality patient care.
How would you identify and manage an acute infusion reaction or anaphylaxis during systemic anti-cancer therapy, SCT?
An acute infusion reaction or anaphylaxis during systemic anti-cancer therapy is a serious medical emergency that requires immediate recognition and intervention. Signs may include flushing, rash, itching, swelling of the face or throat, shortness of breath, wheezing, chest tightness, hypotension, tachycardia, dizziness, or loss of consciousness. Early identification is essential because the patient's condition can deteriorate rapidly. During an oncology placement, I cared for a patient receiving a monoclonal antibody infusion who suddenly complained of itching and difficulty breathing shortly after the treatment began. I immediately recognized these as possible signs of an acute infusion reaction. My first action was to stop the infusion immediately while maintaining intravenous access. I called for urgent medical assistance and followed the local emergency protocol. I quickly assessed the patient using the ABCD approach, monitored vital signs, and administered oxygen as required. I ensured emergency equipment was available and prepared prescribed medications, including antihistamines, corticosteroids, and adrenaline, if indicated. Throughout the event, I remained with the patient, provided reassurance, and communicated clearly with the multidisciplinary team. The patient's symptoms improved following prompt treatment, and further deterioration was prevented. After the incident, I documented the event accurately, completed the required reporting process, and participated in a team discussion to review the patient's future treatment plan. This experience reinforced the importance of close monitoring during SACT administration, rapid recognition of adverse reactions, effective teamwork, and following emergency protocols to ensure patient safety.
What is tumor lysis syndrome, which patients are at high risk, and how is it monitored and managed?
Tumor lysis syndrome, or TLS, is a potentially life-threatening oncological emergency that occurs when a large number of cancer cells break down rapidly, releasing their contents into the bloodstream. This can lead to high levels of potassium, phosphate, and uric acid, along with low calcium levels. If not recognized early, TLS can cause cardiac arrhythmias, seizures, acute kidney injury, and even death. Patients at highest risk include those with rapidly growing and highly treatment-sensitive cancers, such as leukemia and lymphoma, especially when they have a large tumor burden, elevated white blood cell counts, pre-existing kidney impairment, or are starting intensive chemotherapy. However, TLS can also occur in some patients with solid tumors. In my oncology experience, I cared for a patient with newly diagnosed lymphoma who was considered at high risk for TLS before starting treatment. My responsibility was to monitor the patient closely and help prevent complications. Before chemotherapy, we ensured the patient received adequate intravenous hydration and prescribed medications to reduce uric acid levels. I monitored fluid balance carefully, recorded urine output, and performed regular assessments for signs of electrolyte imbalance. I also reviewed blood results frequently, including potassium, phosphate, calcium, uric acid, and renal function tests. Any abnormal findings were escalated promptly to the medical team. Through early risk assessment, preventive measures, and close monitoring, the patient completed treatment without developing severe TLS. This experience taught me the importance of vigilance, early intervention, and multidisciplinary collaboration in preventing serious complications and ensuring safe cancer care.
Describe the clinical presentation of superior vena cava obstruction, SVCO, and the nursing interventions required.
Superior vena cava obstruction, or SVCO, occurs when the superior vena cava becomes partially or completely blocked, most commonly due to a tumor compressing the vessel. It is considered an oncological emergency because it can rapidly affect a patient's breathing and circulation. The clinical presentation often includes swelling of the face, neck, arms, or upper chest, shortness of breath, cough, chest discomfort, headache, dizziness, and visible distended veins on the neck and chest. Some patients may report a feeling of fullness in the head, especially when bending forward or lying flat. In severe cases, patients can develop stridor, confusion, or signs of airway compromise. During an oncology placement, I cared for a patient with lung cancer who developed increasing facial swelling and breathlessness over several days. My priority was to recognize the symptoms early and prevent further deterioration. I performed a thorough assessment, monitored vital signs closely, and immediately escalated my concerns to the medical team. To improve the patient's comfort and breathing, I positioned them in a high Fowler's position and administered oxygen as prescribed. I monitored oxygen saturation, respiratory status, and neurological observations, watching for any signs of worsening obstruction. I also maintained accurate documentation and ensured urgent investigations and treatment plans were coordinated efficiently. Throughout the episode, I provided reassurance to the patient and family, as the symptoms were distressing and anxiety-provoking. Early recognition and prompt intervention allowed treatment to begin quickly, resulting in symptom improvement. This experience highlighted the importance of vigilant assessment, rapid escalation, and supportive nursing care when managing patients with SVCO.
How would you assess and manage severe, unmanaged cancer pain in a patient who is already on a background of modified-release opioids?
Managing severe cancer pain requires a thorough assessment and a patient-centered approach. If a patient is experiencing uncontrolled pain despite being on modified-release opioids, my first step would be to perform a comprehensive pain assessment. I would assess the location, intensity, character, duration, and factors that worsen or relieve the pain. I would also review the patient's current analgesia, breakthrough medication use, side effects, and the impact of pain on daily activities, sleep, and emotional well-being. In one situation, I cared for a patient with advanced metastatic cancer who reported severe pain despite receiving regular modified-release morphine. The patient was distressed, unable to rest, and experiencing reduced mobility. My task was to identify the cause of the uncontrolled pain and ensure timely management. I used a validated pain assessment tool, monitored vital signs, and reviewed how frequently the patient was requiring breakthrough analgesia. I escalated my findings to the medical team and communicated that the current regimen was not providing adequate relief. Following medical review, the patient's opioid dose was adjusted and additional breakthrough medication was prescribed. I monitored the patient closely for pain relief, sedation, respiratory status, nausea, and constipation. I also provided reassurance and involved the patient in discussions about pain management goals. Within a short period, the patient's pain became manageable, allowing them to rest and participate more comfortably in daily activities. This experience reinforced the importance of detailed assessment, prompt escalation, regular reassessment, and holistic care when managing complex cancer pain.
What are the clinical signs of spinal cord compression, and why is it considered an oncology emergency?
Spinal cord compression, or SCC, is an oncological emergency that occurs when a tumor presses on the spinal cord or surrounding structures. It is most commonly seen in patients with metastatic cancers such as breast, prostate, lung, or myeloma. SCC is considered an emergency because delayed diagnosis and treatment can lead to permanent nerve damage, loss of mobility, loss of bladder or bowel function, and irreversible paralysis. The clinical signs often begin with new or worsening back pain, which may be severe and persistent, especially at night or when lying down. Patients may also experience weakness in the arms or legs, numbness, tingling, difficulty walking, reduced coordination, or changes in sensation. As the condition progresses, bladder or bowel dysfunction may occur, including urinary retention, incontinence, or constipation. Any new neurological symptoms in a patient with cancer should raise concern for SCC. During my oncology experience, I cared for a patient with metastatic prostate cancer who reported increasing back pain and difficulty walking. Recognizing these as possible warning signs of SCC, I immediately performed a neurological assessment, monitored mobility and sensation, and escalated my concerns to the medical team without delay. The patient was urgently reviewed and referred for further investigations. While awaiting assessment, I ensured the patient remained safe, minimized unnecessary movement, monitored neurological status closely, and provided reassurance. Early recognition allowed treatment to begin promptly, helping to prevent further neurological deterioration. This experience taught me that timely assessment, rapid escalation, and awareness of red flag symptoms are essential because every hour matters when managing suspected spinal cord compression.
How do you differentiate between radiation-induced skin reactions and standard dermatitis, and what is the appropriate evidence-based skincare advice?
Radiation-induced skin reactions and standard dermatitis can appear similar, but there are important differences. Radiation-induced skin reactions occur specifically in the area exposed to radiotherapy and usually develop gradually during or after treatment. Common signs include redness, dryness, itching, mild swelling, peeling, increased skin sensitivity, and, in more severe cases, moist desquamation where the skin becomes broken and weepy. The reaction is generally confined to the radiation field and corresponds to the treatment area. Standard dermatitis, on the other hand, may be caused by allergens, irritants, infections, or underlying skin conditions. It can occur anywhere on the body and is often associated with exposure to a specific trigger. The distribution and history of symptoms help differentiate it from a radiation-related reaction. In my oncology experience, I cared for a patient undergoing radiotherapy for breast cancer who developed redness and discomfort over the treatment site. My role was to assess the skin regularly, identify any changes early, and provide evidence-based advice to prevent further damage. I encourage the patient to keep the area clean using lukewarm water and mild, non-perfumed soap, gently pat the skin dry, and avoid rubbing or scratching. I advised wearing loose, soft clothing to reduce friction and avoiding extreme temperatures, adhesive tapes, and products that could irritate the skin. I also encouraged the use of approved moisturizers as recommended by the radiotherapy team and stressed the importance of reporting any worsening symptoms promptly. Through regular assessment, patient education, and early intervention, the patient's skin reaction remained manageable, allowing treatment to continue safely and comfortably.
A patient undergoing chemotherapy reports intractable nausea and vomiting despite taking prescribed regular antiemetics. What is your next clinical step?
If a patient undergoing chemotherapy reports severe nausea and vomiting despite taking prescribed antiemetics, my first priority is to perform a thorough assessment and identify any immediate risks. Uncontrolled nausea and vomiting can lead to dehydration, electrolyte imbalance, malnutrition, reduced quality of life, and poor adherence to cancer treatment. In a previous oncology setting, I cared for a patient who continued to experience frequent vomiting despite receiving regular antiemetic therapy. The patient was unable to tolerate food or fluids and appeared weak and distressed. My responsibility was to assess the situation promptly and escalate concerns appropriately. I assessed the frequency and severity of symptoms, reviewed the antiemetic regimen, checked when medications were last taken, and evaluated fluid intake and output. I monitored vital signs and looked for signs of dehydration such as dry mucous membranes, reduced urine output, dizziness, and tachycardia. I also assessed for other possible causes, including infection, bowel obstruction, constipation, metabolic abnormalities, or disease progression. After gathering the relevant information, I escalated the case to the oncology team for urgent review. The patient's antiemetic regimen was reassessed and adjusted, and intravenous fluids were commenced to correct dehydration. I continued to monitor the patient's response, encouraged small, frequent sips of fluid as tolerated, and provided reassurance and emotional support. As a result, the patient's symptoms gradually improved, hydration was restored, and they were able to continue treatment safely. This experience reinforced the importance of comprehensive assessment, prompt escalation, and ongoing monitoring when managing uncontrolled chemotherapy-induced nausea and vomiting.
What protocols and personal protective equipment are required when handling and disposing of cytotoxic waste or body fluids from a patient receiving chemotherapy?
Handling cytotoxic waste and body fluids from patients receiving chemotherapy requires strict adherence to safety protocols to protect patients, staff, visitors, and the environment from exposure to hazardous drugs. Cytotoxic substances can be present in body fluids such as urine, vomit, feces, blood, and sweat for a period after chemotherapy administration, depending on local guidelines and the specific medication used. When handling cytotoxic waste, I follow my organization's policies and use the recommended PPE. This typically includes disposable chemotherapy-rated gloves, a fluid-resistant gown or apron, and eye and face protection if there is a risk of splashing. Hand hygiene is performed before and after PPE use. All contaminated materials, including dressings, tubing, gloves, and disposable equipment, are disposed of in designated cytotoxic waste containers according to local protocols. During my oncology experience, I cared for a patient who experienced significant vomiting after chemotherapy. My task was to manage the situation safely while maintaining the patient's dignity and comfort. I donned the appropriate PPE, cleaned the area according to the cytotoxic spill procedure, disposed of contaminated materials in the correct waste containers, and ensured all equipment was decontaminated appropriately. I also educated family members about safety precautions when assisting the patient. Throughout the process, I followed infection prevention and occupational safety guidelines and documented the incident as required. As a result, the patient's environment remained safe, exposure risks were minimized, and care was delivered without incident. This experience reinforced the importance of following established protocols, using the correct PPE, and maintaining vigilance when handling cytotoxic waste and body fluids.
How do you assess, grade, and manage chemotherapy-induced peripheral neuropathy in an outpatient setting?
Chemotherapy-induced peripheral neuropathy, or CAPN, is a common side effect of certain chemotherapy drugs and can significantly affect a patient's quality of life and ability to perform daily activities. In an outpatient setting, assessment begins with a detailed patient history and symptom review. I would ask about numbness, tingling, burning sensations, pain, weakness, balance problems, difficulty walking, or problems performing fine motor tasks such as buttoning clothes or writing. During my oncology experience, I cared for a patient receiving neurotoxic chemotherapy who reported increasing numbness in both feet and difficulty maintaining balance. My responsibility was to assess the severity of symptoms, identify any impact on daily functioning, and ensure timely intervention. I performed a comprehensive assessment, documenting the onset, progression, and location of symptoms. I evaluated mobility, gait, dexterity, and any safety concerns, such as an increased risk of falls. Using the organization's assessment tools and grading criteria, I recorded the severity of the neuropathy and communicated my findings to the oncology team. Accurate documentation was essential because worsening neuropathy may require treatment modification. To help manage the condition, I provided education on fall prevention, safe footwear, skincare, and protecting numb areas from injury or extreme temperatures. I encouraged the patient to report any progression of symptoms promptly and ensured regular follow-up assessments were completed. The oncology team reviewed the patient's treatment plan, and adjustments were made before the neuropathy became severe. As a result, the patient remained safe, symptoms were closely monitored, and treatment-related complications were minimized. This experience highlighted the importance of early assessment, patient education, and ongoing monitoring in the management of CPN.
What are the key nursing considerations and monitoring requirements for a patient presenting with cancer-related hypercalcemia?
Cancer-related hypercalcemia is an oncological emergency that occurs when calcium levels in the blood become abnormally high, often due to certain cancers such as lung cancer, breast cancer, or multiple myeloma. Early recognition is important because severe hypercalcemia can lead to cardiac arrhythmias, kidney failure, altered consciousness, and other serious complications. The clinical presentation may include nausea, vomiting, constipation, loss of appetite, excessive thirst, increased urination, dehydration, muscle weakness, fatigue, confusion, drowsiness, and, in severe cases, reduced consciousness. As a nurse, my first priority would be to perform a comprehensive assessment and identify any signs of deterioration. In one oncology setting, I cared for a patient with metastatic cancer who became increasingly lethargic and confused over several days. My task was to assess the patient, recognize potential complications, and support treatment. I monitored vital signs closely, assessed neurological status regularly, and reviewed blood results, including calcium levels, renal function, and fluid balance. I ensured accurate monitoring of fluid intake and output because dehydration can worsen hypercalcemia. Following medical review, the patient received intravenous fluids and other prescribed treatments to reduce calcium levels. I continued to observe for changes in mental status, cardiac symptoms, and response to treatment while maintaining clear communication with the multidisciplinary team. I also provided reassurance to the patient and family, explaining the condition and treatment plan in simple terms. The patient's calcium levels gradually improved, and their confusion resolved. This experience reinforced the importance of early recognition, close monitoring, effective hydration management, and prompt escalation when caring for patients with cancer-related hypercalcemia.
How would you care for and maintain a central venous access device, such as a PSC line or Hickman line, to prevent infection and occlusion?
Central venous access devices, such as PSCC lines and Hickman lines, are commonly used in oncology patients for chemotherapy, blood sampling, and administration of medications. Proper care and maintenance are essential to prevent complications such as infection, occlusion, thrombosis, and catheter damage. In my oncology experience, I regularly cared for patients with central venous access devices. My responsibility was to ensure the device remained functional while minimizing the risk of infection and other complications. A key challenge was maintaining strict aseptic technique in a busy clinical environment while ensuring patients understood how to care for their devices. Whenever accessing the line, I performed hand hygiene and followed a septic non-touch technique according to local policy. I assessed the insertion site for redness, swelling, pain, discharge, or signs of infection and checked the dressing to ensure it was clean, dry, and secure. I also assessed catheter length and integrity to identify any signs of migration or damage. To prevent occlusion, I ensured the line was flushed correctly using the recommended technique and solution according to organizational guidelines. I monitored for resistance during flushing, difficulty aspirating blood, or reduced flow rates, which could indicate blockage. Any concerns were escalated promptly. I also educated patients about keeping the site clean, recognizing signs of infection, and reporting symptoms such as fever, swelling, or discomfort immediately. Through regular assessment, meticulous line care, and patient education, complications were minimized and treatment continued safely. This experience reinforced the importance of vigilance, infection prevention measures, and adherence to evidence-based protocols when caring for patients with CVADs.
A patient's family asks you not to tell the patient about their terminal cancer diagnosis. How do you handle this clinically and ethically?
This situation requires a careful balance between respecting the patient's autonomy and understanding the family's concerns. In most international healthcare settings, a competent patient has the legal and ethical right to receive information about their diagnosis and participate in decisions about their care. At the same time, it is important to approach the family with sensitivity and compassion. In a previous clinical situation, a family member asked the healthcare team not to tell a patient about the seriousness of their cancer diagnosis because they feared it would cause distress and loss of hope. My task was to support both the patient and family while ensuring that ethical and professional standards were maintained. I first listened carefully to the family's concerns and acknowledged their emotions. Rather than dismissing their request, I explored why they felt the information should be withheld. This helped build trust and allowed me to understand cultural, emotional, or personal factors influencing their decision. I explained that healthcare professionals have a duty to respect patient autonomy and that many patients prefer to be involved in decisions about their treatment and future care. I then escalated the matter to the multidisciplinary team and ensured discussions occurred in accordance with organizational policies. Before any disclosure, it was important to assess how much information the patient wished to receive, as some patients prefer limited details while others want full information. The outcome was that the patient was given information in a sensitive, compassionate, and patient-centered manner, with appropriate support available. This experience taught me that open communication, respect, empathy, and adherence to ethical principles are essential when managing complex situations involving truth-telling and end-of-life care.
What is your approach to assessing and managing severe cancer-related fatigue in a patient undergoing concurrent chemoradiation?
Cancer-related fatigue is one of the most common and distressing symptoms experienced by patients receiving concurrent chemotherapy and radiotherapy. Unlike normal tiredness, it is often persistent, not fully relieved by rest, and can significantly affect physical, emotional, and social functioning. My approach is to perform a comprehensive assessment, identify contributing factors, and develop an individualized management plan. In an oncology setting, I cared for a patient undergoing chemoradiation for head and neck cancer who reported overwhelming fatigue that was affecting daily activities, nutrition, and emotional well-being. My task was to assess the severity of the fatigue and help improve the patient's quality of life. I began by exploring the onset, duration, and impact of the fatigue using a structured assessment. I reviewed the patient's treatment plan, nutritional intake, sleep patterns, pain levels, emotional health, and current medications. I also monitored blood results and assessed for potential contributing factors such as anemia, dehydration, infection, uncontrolled symptoms, or poor nutritional status. After identifying the likely causes, I worked with the multidisciplinary team to address them. I encouraged the patient to balance activity with planned rest periods, maintain adequate hydration, and participate in gentle physical activity as tolerated. I also provided education on energy conservation techniques and encouraged the patient to prioritize important daily activities. Emotional support was equally important, as fatigue often leads to frustration and anxiety. Through regular review and supportive interventions, the patient's fatigue became more manageable, allowing greater participation in treatment and daily life. This experience reinforced the importance of holistic assessment, patient education, and multidisciplinary collaboration when managing severe cancer-related fatigue.
How would you clinically manage a suspected extravasation of a vesicant chemotherapy agent?
Extravasation of a vesicant chemotherapy agent is an oncological emergency because these drugs can cause severe tissue damage, necrosis, pain, and long-term functional impairment if they leak into the surrounding tissues. Early recognition and immediate intervention are essential to minimize injury. The signs of extravasation may include pain, burning, stinging, swelling, redness, leakage at the insertion site, or the absence of a normal blood return from the cannula or central line. During chemotherapy administration, I closely monitor the infusion site and encourage patients to report any unusual sensations immediately. In an oncology unit, I cared for a patient who complained of a burning sensation around the cannula site shortly after a vesicant chemotherapy infusion had started. My priority was to act quickly to prevent further tissue damage. I immediately stopped the infusion but left the cannula in place, as removing it straight away could prevent aspiration of any residual drug. I disconnected the infusion and followed the organization's extravasation protocol. I informed the oncology team immediately and carefully aspirated any remaining drug from the cannula as per protocol. The affected area was assessed, measured, and documented, including photographs if required by local policy. Depending on the specific chemotherapy agent involved, the appropriate antidote and recommended treatment, such as warm or cold compresses, were initiated according to guidelines. I continued to monitor the site closely, provided pain relief as prescribed, reassured the patient, and ensured accurate documentation and incident reporting were completed. As a result of prompt recognition and intervention, tissue damage was minimized and the patient recovered without significant complications. This experience highlighted the importance of vigilance, rapid action, and strict adherence to extravasation protocols when administering vesicant chemotherapy.
What are the signs of immune-related adverse events in a patient receiving immunotherapy, and how do they differ from chemotherapy side effects?
Immune-related adverse events, or ERAs, are side effects that occur when immunotherapy stimulates the immune system to attack healthy tissues as well as cancer cells. Unlike traditional chemotherapy side effects, which are usually caused by the direct toxic effects of treatment on rapidly dividing cells, ERAs result from immune system activation and can affect almost any organ in the body. Early recognition is essential because some ERAs can become severe or life-threatening if treatment is delayed. Common signs and symptoms include skin rashes, itching, diarrhea, colitis, abdominal pain, cough, shortness of breath, pneumonitis, hepatitis, jaundice, fatigue, headaches, visual disturbances, and endocrine problems such as thyroid dysfunction or adrenal insufficiency. Patients may also develop unexplained muscle weakness, joint pain, or neurological symptoms. One challenge is that these symptoms can appear weeks or even months after treatment has started and may initially seem unrelated to immunotherapy. During an oncology placement, I cared for a patient receiving immunotherapy who developed persistent diarrhea and increasing fatigue. My role was to assess the symptoms thoroughly and determine whether they could represent an immune-related complication. I performed a comprehensive assessment, monitored vital signs, reviewed symptom progression, and escalated my concerns to the oncology team promptly. Further investigations confirmed an immune-related adverse event, and treatment was adjusted accordingly. I monitored the patient closely, provided education about reporting new symptoms early, and supported ongoing management. The patient's condition improved with timely intervention. This experience taught me that ERAs differ from chemotherapy side effects because they are caused by immune system overactivity rather than direct drug toxicity. Careful assessment, patient education, and prompt escalation are vital to prevent serious complications and ensure safe immunotherapy treatment.
How do you utilize the Bristol stool chart and clinical grading to monitor and manage chemotherapy-induced diarrhea?
The Bristol stool chart is a valuable assessment tool that helps nurses objectively monitor bowel movements and identify the severity of chemotherapy-induced diarrhea. It provides a standardized way to describe stool consistency, ranging from type 1, which indicates severe constipation, to type 7, which represents entirely liquid stools. In patients receiving chemotherapy, frequent type 6 or type 7 stools may indicate significant treatment-related toxicity and require prompt assessment. In an outpatient oncology clinic, I cared for a patient receiving chemotherapy who reported multiple episodes of loose stools each day. My task was to assess the severity of the diarrhea, identify potential complications, and ensure appropriate management. I used the Bristol stool chart to help the patient accurately describe stool consistency and documented the frequency, volume, and duration of symptoms. I also assessed for associated symptoms such as abdominal pain, cramping, fever, dizziness, dehydration, reduced oral intake, and signs of infection. Using clinical grading criteria, I evaluated how the diarrhea was affecting the patient's daily activities and overall condition. This information was communicated to the oncology team to support treatment decisions. I monitored fluid balance carefully and encouraged adequate hydration. The patient received education about recognizing signs of dehydration and the importance of reporting worsening symptoms promptly. I also reviewed dietary advice and ensured prescribed antidiarrheal medications were being taken correctly. Through regular assessment, accurate grading, and early intervention, the patient's symptoms were controlled before serious complications developed. This experience demonstrated the importance of structured assessment tools, clinical judgment, and patient education in the safe management of chemotherapy-induced diarrhea.
What clinical assessments and support would you put in place for an oncology patient experiencing severe mucositis?
Severe mucositis is a common complication of chemotherapy and radiotherapy that can cause significant pain, difficulty eating and drinking, increased risk of infection, and reduced quality of life. My approach is to perform a thorough assessment, identify complications early, and provide comprehensive supportive care to maintain the patient's comfort, nutrition, and safety. In an oncology setting, I cared for a patient receiving treatment for head and neck cancer who developed severe oral mucositis. The patient reported intense mouth pain, difficulty swallowing, reduced oral intake, and increasing fatigue. My responsibility was to assess the severity of the condition and ensure appropriate interventions were implemented. I began by conducting a detailed oral assessment, examining the mouth for redness, ulceration, bleeding, swelling, white patches, and signs of infection. I assessed the patient's pain level, ability to swallow, nutritional intake, hydration status, weight changes, and overall impact on daily activities. I also monitored vital signs and reviewed blood results, particularly if infection or neutropenia was a concern. After assessment, I escalated my findings to the multidisciplinary team. Pain management was optimized, and prescribed mouth care treatments were administered. I encouraged regular oral hygiene using gentle techniques and recommended avoiding foods that were spicy, acidic, rough, or extremely hot. I worked closely with dietitians and other team members to support nutritional intake and hydration. Through regular monitoring, effective symptom management, and multidisciplinary support, the patient's discomfort was reduced and nutritional status was maintained. This experience reinforced the importance of early assessment, proactive symptom control, and holistic care when managing severe mucositis in oncology patients.
Can you describe the clinical indicators that suggest a patient is transitioning into the end-of-life phase and how this shifts your nursing priorities?
Recognizing that a patient is transitioning into the end-of-life phase is essential because the focus of care changes from curative or life-prolonging treatment to comfort, dignity, and quality of life. While each patient is different, there are several clinical indicators that may suggest a patient is entering the last days or hours of life. These include increasing weakness and fatigue, spending most or all of the time in bed, reduced mobility, decreased oral intake, difficulty swallowing, reduced level of consciousness, increasing drowsiness, changes in breathing patterns, noisy respiratory secretions, reduced urine output, cool extremities, and a gradual decline in overall physical function. I cared for a patient with advanced metastatic cancer whose condition deteriorated over several days despite ongoing treatment. The patient became progressively weaker, stopped eating and drinking, slept for most of the day, and became less responsive. My role was to recognize these changes, communicate concerns to the multidisciplinary team, and ensure that care remained focused on the patient's comfort and wishes. As the patient's condition changed, my nursing priorities shifted. I focused on symptom management, including pain, breathlessness, anxiety, agitation, and respiratory secretions. I performed regular assessments to ensure comfort and administered prescribed medications promptly. I also provided mouth care, pressure area care, and repositioning to maintain dignity and prevent discomfort. Equally important was supporting the family. I communicated honestly and compassionately, explained what changes they might observe, and provided emotional support during a very difficult time. By focusing on comfort, dignity, communication, and holistic care, the patient remained peaceful and comfortable, and the family felt supported throughout the end-of-life journey.